Okay, so here is our narrated lecture for Chapter 41. I'm sorry about the delay. I've had some technical difficulties getting this recorded and uploaded at home, so thanks for being patient. Vocabulary for this chapter: constipation and diarrhea should not be new concepts for you at this point. Antiflatulence work against flatus, flatus, you can say it either way, which is gas. Dyspepsia is that fullness or epigastric discomfort that accompanies things like GERD, acid reflux, that kind of thing. Inflammatory bowel disease is an umbrella term that encompasses disorders and diseases like Crohn's and ulcerative colitis, shortened to IBD. Obstipation is watery stool leakage around a hard fecal impaction. This is an important concept to be aware of. A lot of times people will think their patient has diarrhea when indeed they have an impaction, but the stool is allowed to leak around the side of it, so it kind of creates a situation where we don't always catch on right away to what it is. The lower GI tract is comprised, most importantly, of the large intestine. It is responsible for the absorption of water back into the system and some nutrient, especially our fat-soluble vitamins, and we'll talk about those coming up. If we have too rapid of transit through the large bowel, we end up with diarrhea because the water is not able to reabsorb. Sluggish transit, therefore, equals constipation. So we've got loss of water, too much water coming out, or another factor is involved, such as an opioid or something along those lines that's causing constipation. Lots of factors can affect the passage of stool, including IBS, which is irritable bowel syndrome, so that can encompass diarrhea or constipation, and IBD, those inflammatory bowel diseases like Crohn's and UC. We're only going to talk about 3 groups of drugs: the aminosalicylates and a couple of others that are thrown into that category: antidiarrheals, antiflatulents, and laxatives. Our first group, aminosalicylates, if it sounds familiar, then that's because you remember salicylates we've looked at before. So these are an aspirin-like compound. And what they have is that anti-inflammatory action, and they exert a topical effect in the bowel to stop and decrease that inflammation. They're also known as the 5-ASA medications. We're just going to refer to them as aminosalicylates. They are used to treat things like Crohn's, ulcerative colitis, and inflammatory diseases because of their anti-inflammatory effect. GI system reactions are abdominal pain, nausea, and diarrhea, which ironically are also symptoms of the disorders they treat. General adverse reactions are reported as headache, dizziness, fever, and weakness. These are contraindicated in anyone that has a hypersensitivity to salicylate medications, as well as, I want you to remember this, there is a cross hypersensitivity to sulfa. So if somebody has a sulfa allergy, they should not take any of the medications in the aminosalicylate group. They are used cautiously in patients during pregnancy and lactation. Aminosalicylates also interact with a few different drugs. I want you to focus though on oral hypoglycemic medications. These drugs, when taken with the aminosalicylates, are rendered less effective, so we could have increased blood glucose level. Just as a side note, remember that some of our oral hypoglycemics are also sulfa medications, so it's just kind of interesting how some of these are related. There are some biologic agents that are discussed in this group as well. They're not part of the aminoglycosate or aminosalicylate group, but they're used to treat irritable bowel disease. So one of the medications that is discussed in detail is Tysabri. It's associated with a rare brain infection called leukoencephalopathy, and it's only given in specially trained facilities, so chances are you're not going to be given this medication. However, you may see some of the other biologic agents used for the treatment of some of these inflammatory diseases, and we'll talk about those coming up. Okay, here are our list of medications. The aminosalicylates are listed there. You'll see sulfasalazine is making an appearance again as aminosalicylate. Biologics for bowel disorders. So these are the ones I said you may see coming across. You may recognize them from TV ads. So things like Humira and Remicade are used for those inflammatory bowel diseases. Okay, moving on to antidiarrheals, obviously used in the treatment of diarrhea, acute diarrhea, but also can be used for chronic disorders associated with irritable bowel disease or irritable bowel disorder, my apologies. Um, there is a couple of these drugs that are considered opioids or opioid related, and they have the sedative and euphoric effects. So people can become addicted or dependent upon these drugs, but there's no analgesic activity. So diphenoxin and diphenoxylate, modafinil and Lomotil respectively, both produce sedative effects, euphoric effects. People can become dependent upon them, but if they're taking this drug for a disorder, then they also have something like chronic back pain. It's not going to provide relief from the chronic back pain, but it does have these other things. What we are wanting to get basically is the side effect of that opioid. So that's what makes these effective. Remember, opioids cause constipation by slowing GI motility. So in this case, that's a desired effect. So that's why we use these medications. But you have to be very careful because of the possibility of abuse and dependency, as well as sedation, and we'll talk about some of that coming up. Remember, we never treat diarrhea until we know the cause. So antidiarrheals are not used in certain infections like C. diff, salmonella, and shigella. Remember that in those cases, we want those organisms to be shed from the stool. We don't want to trap them in the bowel. It could cause increased pseudomembranous colitis, as well as toxic megacolon. These drugs are not to be used in children under 2 years old. Remember that if diarrhea persists more than 2 days, you should tell people to quit using their over-the-counter antidiarrheal and seek help from their provider. Could be a more substantial issue occurring. Antidiarrheal adverse reactions, we've got gastrointestinal reactions like anorexia, nausea, vomiting, constipation, abdominal discomfort, pain, and distension. Just because it's causing us to retain some of that water, they might feel a little bit distended. Other reactions, dizziness, drowsiness, headache. Definitely sedation and euphoria for those 2 medications that are considered to be part of the opioid class, and then possibly a rash. They are contraindicated in patients whose diarrhea is associated with an organism that can harm the intestinal mucosa. So those things on the list like C. diff, shigella, salmonella. And then we're not going to give antidiarrheals in children younger than 2 years old. They're to be used cautiously in patients that have pseudomembranous colitis, abdominal pain of unknown origin, or obstructive jaundice. So in the event that we want things exiting the body, we're not going to try to hinder that process with an antidiarrheal. Educating the patient and family is going to include explaining the importance of taking the drug as directed. Emphasize observing caution when driving or performing other hazardous tasks, especially with those opioid medications, as well as instructing people to not use alcohol or other CNS depressants if they're on either of the opioid medications. Interactive drugs, really just be careful that we don't give anything sedating if we're giving an opioid type antidiarrheal. So antihistamines, other opioids, sedatives, hypnotics could cause that profound CNS depression, and we could have some big issues then. Your antidiarrheals are listed here, so things like Pepto-Bismol. You'll see the modafinil and Lomotil listed there, the diphenoxin and the diphenoxylate. So both of those contain the drug atropine as well, which is has the anticholinergic properties of drying things out. So just pay close attention to those. Loperamide, you definitely want to cue in on that. That is the kind of gold standard antidiarrheal. You will see that in practice. It's in things like Imodium, kaopectate, Maalox, antidiarrheal, all of those things contain loperamide. Lastly, you'll see that tincture of opium can be used for severe diarrhea. So that is kind of the granddaddy of opioids being used for its essentially side effect of creating constipation. Antiflatulants are basically just two medications we're going to discuss: simethicone and Mylocon, or simethicone, which is also Mylocon, and charcoal. They both work to help the body release gas by either belching or flatus. Simethicone works by having a defoaming action, so it disperses and prevents that formation of those gas pockets and bubbles. So kind of settles that right down and breaks it down for expulsion. Charcoal helps bind gas for expulsion. So the way charcoal works is just by absorbing everything around it. So it includes those gaseous type substances. These medications are used to relieve painful symptoms of gas in the digestive tract. So it could be caused by post-operatively. So we blow people up full of gas intentionally, especially if it's abdominal surgery, so we can better visualize things, get around in there. Also for air swallowing, for different reasons. It can be used for gas associated with dyspepsia, peptic ulcers, irritable bowel syndrome, diverticulosis. So no adverse reactions are reported with these medications. There may be that 1 in a million chance that somebody has a hypersensitivity, to it, but overall a relatively safe drug to use. The only thing of special importance that I want you to be aware of, remember, charcoal absorbs everything, and if you recall, it's one of the medications that we use for the treatment of intentional or accidental poisoning, because it just sucks everything into it. So know that if charcoal is used as an antiflatulent, it's going to absorb other drugs in the GI tract. So, if they've just taken their antihypertensive or cardiac medication and they're using charcoal as an antiflatulent, it may render those medications, important medications, useless, and that could have adverse effects. When educating the patient and family, emphasize the importance of chewing the tablet. So simethicone tablets have to be chewed up entirely before they're swallowed. That's why we do the simethicone or Mylocon drops for babies, because they can't chew. But this activates it and allows it to go work on the GI tract when it reaches the stomach. Explain the necessity of contacting the primary healthcare provider if those symptoms are not relieved by the use of these medications, because it could be indicative of a larger problem. Here's our two antiflatulants listed. Charcoal is branded as Charco Caps, Flatulex. Simethicone is branded as Gas-X. Mylocon, it's in Maalox anti-gas and in Mylanta both. So very common drug. Okay, we're going to talk about our laxatives, which are a little bit more involved than some of our other meds that we're talking about today. They are used for the relief of constipation, of course. There are several different types, so I'm going to point out a section in the book that I want you to study and be very familiar with the types of laxatives and how they work. So the groups stimulant, emollient, and saline laxatives all evacuate the colon for rectal and bowel exams. So by different mechanisms of action, it helps remove all of that fecal material from the bowel. Stool softeners and mineral oil prevent difficulty in straining. So stool softeners make that stool more moist by pulling some water into the bowel, softening it up, easier to pass. Mineral oil, just by the mechanism of action of being oil, makes it more lubricated and easier to evacuate. So this is important for our patients after surgery, when we don't want them straining to have a bowel movement, or people that have those cardiac issues that we don't want to have them straining and vagling. So we talked about the possibility of compression of that vagus nerve and causing someone to pass out or even die from straining to pass stool. So this is preventative in that situation. We also have our psyllium and polycarbophil or bulk forming laxatives. So they pull water into the bowel and are helpful for IBS of a constipation type nature. Obviously not if it's IBS of diarrhea and diverticular disease. So if you guys remember back in fluid electrolyte, that bowel becomes the semi-permeable membrane, and this laxative material is the solute on the inside that's going to pull water in through diffusion to try to create equilibrium. As it pulls water in, it softens the stool and allows it to pass. Hyperosmotic or lactulose agents. This medication is used for extreme constipation. So if somebody has a partial obstruction, partial fecal impaction to try to pass that stool. But also, and maybe more commonly, it's used to reduce ammonia levels in hepatic encephalopathy. So for your patients that are in end-stage liver disease, the liver is no longer filtering out the toxic waste ammonia, and it begins to build up, causing increased confusion and all kinds of horrible things. And lactulose binds that ammonia and allows it to be excreted into the stool. Please read the chronic care consideration about constipation below and kind of look at how that medication can help with constipation caused by opioids. Okay, this is the page in the book, 471. I want you to study this box, and I want you to know the different types of laxatives listed here and associate with it the drug that is mentioned as an example. We have so many different types of laxatives for use. It is important to understand how they work because one size doesn't always fit all, and we need to understand why we're giving it, if it's safe to give it to our patient. One laxative may cause harm, and another one performs the job, without issues. So that's why I want you to pay so much attention to how these different laxatives are designed to work for your patients. Adverse reactions, we could have rebound constipation. So especially for people that abuse laxatives, they decrease that gastrocolic ability to move stool on their own, essentially. And so they are dependent upon the laxative to produce the results. And so they're kind of chronically constipated then. Diarrhea can be the result of abuse of laxatives. So, we may go so far as to cause increased loss of water and electrolytes and can cause some issues there. Abdominal pain and discomfort can definitely accompany laxative use. Nausea and vomiting can occur. Perianal irritation, mainly from the production of diarrhea. It can cause fainting. It can cause bloating as it draws fluid into the bowel. It can produce flatulence, which can be a positive thing to help move stool, but it can also cause cramps and uncomfortableness with that, weakness. Prolonged use of a laxative or laxative abuse can cause serious electrolyte imbalances. Some people become very focused on their bowel, especially our elderly population, and if they haven't had a bowel movement by 2:15, because they do every single day, they're asking for a laxative. They're definitely physically and psychologically dependent upon having that to have that bowel movement occur. Administering bulk forming laxatives has been associated with obstruction, sometimes in the esophagus, stomach, small intestine, and colon, so we have to be aware of that. Contraindications and precautions with these medications, of course, if there's a known hypersensitivity, as always. If somebody has persistent abdominal pain, nausea, vomiting, we're not going to keep giving this medication. It needs to be investigated. It could be an intussusception, a volvulus. It could be some sort of obstruction in the bowel that could cause bowel death. So we don't want to just keep pushing a laxative. If they have signs of acute appendicitis, we're not going to give laxatives. That can be very dangerous. Fecal impaction. Again, sometimes we will use something like lactulose or even Miralax to help that fecal impaction perhaps pass, but that's just going to be in a partial obstruction of no, we know it's fecal material. An intestinal obstruction of any kind, especially if it's a mechanical obstruction, we're not going to give laxatives. We need to, do the appropriate intervention, perhaps surgical, to take care of that. And in acute hepatitis, we're not going to administer laxatives. Used cautiously in patients that have rectal bleeding. It can increase bleeding. And then during pregnancy and lactation, be careful. As far as the very young and very old or debilitated people, they are at risk for aspiration of mineral oil. It can cause a specific pneumonia called lipid pneumonitis. So make sure that you're aware of that you shouldn't use those particular laxatives in these groups of individuals. Okay, so here's some things you definitely need to remember about laxatives. Two biggies on the screen. One, mineral oil impairs the absorption of fat-soluble vitamins. So mineral oil laxatives can decrease absorption of vitamin A, D, E, and K. So remember your fat-soluble vitamins and know that mineral oil laxatives can cause a big issue with those. So remember, those vitamins cannot be synthesized. We have to get them in our diet, and lack of such can be very detrimental to health. So, and actually, I take that back. I have to correct myself. We can synthesize vitamin D, but our other fat-soluble vitamins, we need to make sure that we have adequate access to. Laxatives can reduce absorption of drugs, any laxative and any drugs in the GI tract, because it can hasten them through the intestinal tract too soon, so they don't get to absorb, or they can just combine with them chemically and kind of block their action. So something to pay attention to, especially if you've got somebody that is a chronic laxative abuser. Surfactants, when administered with mineral oil, can increase mineral oil absorption, so that can be a good or bad thing. So providers should always be included if somebody's using a mineral oil laxative. Mineral oil should be given to the patient on an empty stomach in the evening. Remember that milk, any antacids, the histamine H2 antagonists, and proton pump inhibitors should not be given within 1 to 2 hours before anything really, but especially the bisacodyl tablets, because it can dissolve the enteric coating and render them ineffective. And then here's the other biggie. Besides the mineral oil interfering with absorption of fat solubles, here's the other biggie. If you're giving a bulk producing or stool softening laxative, another reason to study that table and know how these medications work and which ones they are, you want to give it with a full 8-ounce glass of water or juice. They require the fluid to be effective, and it has to be taken with that medication. Okay, more about laxatives. Before administration, you want to thoroughly mix or stir that are powders, flakes, or granules. So things like Metamucil, you don't want to leave them clumpy. They're not very palatable as it is, and they're not going to be as effective unless you dissolve them thoroughly in that solution. Explain that some laxatives have an unpleasant or salty taste. Miralax, I've heard by multiple people, has a very salty taste, as does Go Lightly. Emphasize the importance of avoiding long-term use of products unless recommended. So this is the biggie on this screen. Laxatives should be used as needed unless it's for a prophylactic type intervention, like after surgery. We don't want somebody straining. We don't want a cardiac patient vagaling. Otherwise, you're going to use laxatives for constipation as needed. Make sure that if they don't work within a couple of days, it's being reported. It should never be a chronic over-the-counter issue. They should never be used for weight loss. That's another big reason that people become dependent upon them. So there's definitely the risk of habit forming and dependency upon them. Instruct patient not to use products in presence of abdominal pain, nausea, and vomiting. So if somebody is on a laxative and they become ill with the flu or something like that, these can only further compound and increase the risk of dehydration and fluid and electrolyte imbalances. So they can become very dangerous then. You need to make sure they understand that when they're taking a laxative, they need to drink plenty of fluids. They need to be getting exercise, eating foods high in bulk or roughage. So these interventions right here as well can prevent constipation and help avoid the use of laxatives entirely. Inform about discoloration of urine that may occur with some laxatives. So Cascara sangrata or Senna, which Senna is used in medications like Senecot, um, can make urine kind of a pink-red color, red-violet, or red-brown, a yellow-brown, or even like a black discoloration, especially the Cascara sangrata. So if someone is using any of these types of laxatives, or this is a component of the laxative they're taking, make sure they understand, because remember, when people's body fluids start changing colors, they freak out if you haven't given them a heads up. Here are your list of your laxatives, so several here, many of them over the counter, so they should be very familiar to you. I would go through and highlight those examples that the book gives you of the different classes and the different groups, just so you kind of know and have an idea of how they're working when you're giving some of those medications. So I'll give you kind of the down and dirty. So those bulk producing laxatives, they're the ones pulling water into the bowel, like I talked about through diffusion. So they're softening the stool and allowing it to pass by pulling water from other areas in the body. The emollients, as gross as it sounds, make the stool more slick, easier to move through because it's oil. We're talking about the mineral oils, and we know that the risk there is they prevent the absorption of our fat-soluble vitamins. The stool softeners and surfactants are the ones that just allow the stool to be softer and pass more easily. They do not have a stimulant in them. They do not cause someone to go. So that's something that people a lot of times don't understand with medications like Colace. They think it's going to cause them to go, but actually it doesn't, just makes it easier to go. The hyperosmotic agents are things like that lactulose. That's the big one I want you to remember. And they're only used for severe constipation. And like I said, in the event of hepatic encephalopathy, lactulose helps the expulsion of that ammonia that's built up. Irritant or stimulant laxatives, these are the ones that do cause the person to go. So this is your Senna, this is your Cascara Sagrada, that both of those can cause discoloration to the urine. And then also includes the bisacodyl, like the Ducalax. And so they're going to cause or stimulate the bowel to move. So it increases that gastrocolic reflex. Saline laxatives also work by moving fluid within the bowel. So they have a sodium type component, and you know what follows sodium. Hopefully you say water at this point. If you hear that, yes, my husband is hammering on the outside of the house. I apologize. So they contain magnesium and sodium electrolytes that are going to attract water into the bowel. So that's how those work. The bowel evacuants are things like Miralax, Go Lightly. These are the big guys. They're used for bowel prep typically. Now, Miralax in smaller doses can be used for chronic constipation, and lots of elderly people get prescribed Miralax, and I hate it, but they do become dependent upon it. But Go Lightly, that's not something that we use regularly to treat constipation. It is used for bowel prep, and it's anything but Go Lightly. It clears out the bowel. You know it's effective when the stool that is exiting the rectum is completely clear water. If there's any color to it, then their bowel prep is not complete. Okay, for all medications that we discussed now, we've covered them all. These are things to remember. You're always going to review the patient's chart for medical diagnosis and the reason that we are giving the drug. That's why it's important to know the different types of laxatives, how they work, and why you're giving it to that particular patient. But for all drugs, you should know that. Question the patient regarding type and intensity of symptoms, how long it's been going on. You need to establish a baseline of what their regular bowel patterns are so that you can evaluate the effectiveness of the drug therapy. You know, some people have a bowel movement every single day. Some people have one every third day, and neither is right or wrong. It's just what is normal for that patient. Auscultate bowel sounds. This is the number one thing that you can do without doing some sort of a test or invasive procedure. This is what we got. We can listen to their bowel sounds. If they're very hyperactive because the patient is experiencing acute diarrhea, as we treat it, we should begin to hear them slow. Same goes for constipation. If they're very sluggish, we should see improved bowel sounds if we're able to give them a laxative and get bowels moving again. Remember, in the absence of bowel sounds, that's considered a medical emergency. You need to report that immediately. Palpate the abdomen. If there's any guarding or discomfort, determine the cause of that. Look for the location. Remember signs and symptoms of appendicitis or anything that could alert you to a serious issue that we would not administer the laxative. Ongoing assessment, monitor for relief of symptoms. Look at their vital signs. If they're having severe diarrhea, watch more closely. They're at big risk for fluid and electrolyte imbalance. They could have severe dehydration. Their sodium, potassium especially could become very depleted. Observe for any adverse reaction, evaluate effectiveness, and then we're always going to be monitoring stools before and after administration of treatment, looking for improvement. If somebody does suffer from imbalanced fluid volume, make sure that you notify the primary health care provider. If they run a fever or have any severe abdominal pain, you want to make sure that they don't have one of those infections we talked about, like C. diff. If they have any abdominal rigidity, it could be a sign of an appendicitis, of a rupture. Monitor fluid intake very closely, as well as output. We would be measuring liquid stool, including it in liquid output. Cleanse the area around the rectum after each bowel movement gently with mild soap and water. Apply emollient for any perianal irritation. Diarrhea, especially to any person of any age, especially if there's incontinence involved, can really tear the skin up very quickly. Use barrier creams as appropriate to prevent that breakdown. Record bowel movement results when a laxative is administered. So we want to make sure that we note that it's working because we're going to stop using it once they begin passing stool on their own. Notify the primary healthcare provider if excessive bowel movement occurs or if there's prolonged diarrhea or if the laxative is ineffective. To evaluate that the drug has had its therapeutic effect, you can read through these. Basically, we're going to see the desired effect achieved, any adverse reactions identified and reported, and the patient understands the drug regimen, treatment, follow-up, and all of the things we discussed in these slides. Happy studying!